Hi everyone, today we are doing some PDO lifting threads. This patient has had threads before as well as some filler, but today we're doing maintenance. Her main concerned area was a little bit of pocketing right in her oral commissure marionette area. So it's a little bit more apparent on the other side, but you can kind of see here, I'm just kind of pinching and pulling and seeing where I'm getting the best pull. We are doing 4 threads per side starting out. I do think I ended up adding a thread to the side that was a little bit worse. That's the side that she sleeps on. Whenever I'm doing threads, it's really hard to estimate how many you're going to use. So typically I mark the patient when they're sitting up, and then when I'm kind of halfway through, I'll set them up again, look at side by side, then I'll go to the other side, treat, and then set them up again at the end and kind of finalize whether or not I want to add another thread or not. This way, I'm just making sure that I am getting as close to symmetry as possible. But starting off, we have our lines marked. I went ahead and used an 18 gauge needle to go ahead and make my entry point for my cannula. She was bleeding a little bit on this side, so I apologize. I'm kind of dabbing quite a bit. I do use lidocaine with epi to help control a little bit of the bleeding, but in some instances, I must have been right above a vein. So, I went ahead and had a little bit of bleeding there, but it is not the end of the world. I'm just dabbing as I'm going through. If you have an assistant, even better. They can kind of be controlling that as you're going along and treating. But I am just using my cannula here. This is a 75 millimeter cannula, and I am just making tracks. I'm making vectors for my threads to sit. Personally, I do not add that much lidocaine as I'm coming out. I don't like my threads to have any sort of liquid that they're floating in, but I'm always kind of asking my patient. So right there, she was a little bit more uncomfortable. She's had threads in the past, so her tissue was quite tight to get through, so I had to push a little bit. So whenever my patient is kind of stating, it's a little bit uncomfortable, I'll of course go ahead and give them a little bit of anesthetic. But if they don't need it, I don't use it because I would rather not have that fluid sitting in that vector. But I'm just kind of using the curtain over curtain rod technique, a little bit of twisting as well to my cannula just to get all the way to the bottom of my vector. And this is where an assistant would come in handy. I was kind of preoccupied with my hands there. She was bleeding a little bit. We went ahead and got that cleaned up. Now we're going in with our threads. This is a 19 gauge 100 millimeter thread. I am starting out with my nasolabial fold vector. I always like to lift top to bottom. And as you can see, once you have that vector kind of pathed out with your cannula, it's very easy to go in there with a larger gauge. So I'm just putting some gentle pressure and I'm pulling that tissue up and over those barbs and just kind of giving it a gentle pull and pulling it into place. Sometimes I cut my threads as I'm kind of going along, or you can leave them. It's totally up to you. Once I get to 3 or 4 threads, I always cut just because you will kind of run out of room there. But just going ahead and cutting my thread, getting a little bit cleaned up, and we're going to go ahead and place our second. This is an 18 gauge 100 millimeter thread. So again, just using that curtain over curtain rod technique, I'm going to advance all the way down into that jowl area. And as you can see, I'm always kind of tenting up as I'm going along because I want to make sure I'm in the same depth for the entire vector. I don't want any sort of lumpy, bumpy puckering or anything like that. That is when you run into issues with puckering post-treatment, having that complication of thread visibility. So you want to make sure that is as smooth as possible. So then going in and just doing the same exact thing I did for my initial thread. And you can see that that really pulled up her jawline. It's looking really nice. All of that puckering there is going to go away here in a moment as soon as I smooth over that thread. But just cutting as close as possible and using a little alcohol swab to just pop that right into place. And as you can see, I just use my thumbs just to smooth that out. She has one little pucker there that I'm going to get here in a moment. I place Band-Aids just to keep that area clean for the next few hours. I have my patients leave them on until the end of the day, wash their face before bed, and then they can go ahead and take those off. This is again my lidocaine with epi, just helps with bleeding. Same process for this vector. I'm going in with my 18 gauge needle. Right off the bat, you want to be in that correct plane, so always tent up and make sure you like your placement. You want to make sure that these are superficial. We do not want to be near that muscle. That increases your risk of your thread breaking, and you're not going to get as good of a result. But really, for complication, we want to make sure we are away from any major vessel and nerves, especially because this thread is going to be staying behind. So depth is very, very important. Again, curtain over curtain rod. I'm also just kind of pushing and doing a little twist. Like I said, this patient has had threads previously. She keeps up with her skincare, so she has really nice skin quality here. So I do have to push a little bit harder. Same thing with someone who maybe has had acne scarring in the past, something like that. It will be a little bit more difficult to get through that tissue if you are in the correct plane. But as you can see, once you're in that correct spot, it's pretty easy to glide. Just giving a splash of lidocaine, like I said, you don't want too much, and then going in with my 19 gauge 100 millimeter thread. Following that same exact process, always using my other hand to ensure that I like my depth. And then I do use that 3cc syringe on the end. I've been doing this recently. I just find if I do need to back up or readjust, I would rather just have that ready to go. If you are backing up and you don't have anything on the end of that cannula holding that thread, it will engage. And if you're in the incorrect plane, it's going to engage and it's going to stay, and it's going to be very difficult to get out. So I just throw that 3cc on the end. I hold my thread in place. That way, if I do need to back up for whatever reason, I can. Like I just mentioned earlier, I don't have an assistant when I am treating, so I just try to make my life as easy as possible and have everything ready to go if I were to need it. I don't back up that often. As you can see, I just backed up slightly right there, but that's why it's on there. You know, my goal is to go as smoothly through the tissue as possible to avoid pain for that patient. But if I needed to back up like I just did, it's on there, ready to go. And that way I know that I'm always going to have a very smooth plane, no lumps and bumps, so we decrease that risk of thread visibility. I went right into that pocket, and now just going ahead and following that same process of pulling back and popping that thread into place. I always give a small tug. You don't want to be pulling these threads out by any means, but just a gentle pull just to make sure everything is engaged, and cutting as close to that skin as possible so that thread is able to pull back and snap right into that space. So again, we don't have any thread visibility. And now she has a very smooth and even result. So I'm going to go ahead and put a Band-Aid on, and we will do the other side. And this is a side by side, and you can just see how lifted her cheek is, how lifted her jawline is, and the other side was her concerned area. So we'll go ahead and work on that.